Okay, so good morning, good afternoon, and good evening, everyone. I would like to extend a warm welcome to all participants joining us now from Europe and from all over the world for this sixth session on the European Climate Resilient Health System course, joint venture from the GCCHE from Columbia University and ASFER, the Association of Schools of Public Health of the European region. My name is Eric Toomey. I'm a current fellow in climate and health at ASFER itself. And before starting with this session today called Health Early Warning Systems and Surveillance in Changing Climate, I would like to briefly repeat the formalities and logistics of this 10-course webinar. To do that, I would like to briefly outline the course objectives again. For those who have been present in the last sessions, this will be quite a little bit repetitive, however, still important to say out. First objective is to articulate and communicate to key partners and the public the unique challenges of the health system facing in a changing climate. Then apply methodology and frameworks for assessing vulnerability and adaptation for health systems in any context. Apply approaches for measuring and monitoring the environmental sustainability of health systems and health co-benefits of transitioning to green health systems. Apply a health equity lens into efforts to address health system decarbonization and climate resilience. And finally, develop an initial plan to increase the resilience of a health system vis-à-vis the estimated climate impact on the population and to engage with key partners to achieve meaningful adaptation. This is the course schedule. We are now in session 6 on this March 11th. There will be 4 further sessions coming up in March and April. So the learning objectives will be explain the core components of early warning systems, including data collection, risk assessment, and communication strategies, and how these systems mitigate health risks in the context of climate change. Identify and evaluate climate-sensitive health indicators and their integration into surveillance systems for timely and effective public health responses. And third, explain how to enhance health surveillance frameworks that incorporate climate change projections, stakeholder engagements, and technological innovations to improve community resilience and preparedness. So this is again a 90-minute session. It includes the expert lectures and case studies. The session will terminate in a Q&A section, and all of you are invited to enter your questions for the presenters in the Q&A section of this meeting. When doing this, please indicate which speaker you would like to direct your question to. And the session's video recordings and the slide decks and all other resources will be made available on the course website where you have registered. The attendance is automatically recorded during the live Zoom sessions. However, it's only then counted when you use your individual attendance, your personal Zoom link. The attendance is not counted if you join with the colleagues link, and YouTube views will also not count towards attendance. You will obtain a certificate of participation at the end if you have attended more than 70% of all live sessions and passed the final exam with a score of more than 70% at the end of the course. This will be awarded by ASFER and GCCHE. And the certificate of participation is only available to those who have used the same email for registration, all Zoom sessions, and the exam. So please make sure that you're using the same email. The final exam must be completed using, again, the same email address. And the exam will be sent on the final day of the class by an email and WhatsApp, and will close on Sunday. The format will be roughly 25 multiple choice questions or true and false questions. And you should be prepared to take the whole exam in one sitting. And with this, I would like to pass on to my esteemed colleague, Doris Zjalic, and co-moderator, to present our today's speakers.
Thanks, Eric. Good morning, good afternoon, and good evening, everyone. I'm Doris Zjalic, a PhD candidate at the Erasmus University in Rotterdam, Netherlands. And today we are incredibly fortunate to have with us Dr. Jan Semenza, a leading figure in the field of environmental epidemiology with over 30 years of experience at the intersection of climate change and health. Dr. Semenza led the CDC's response to the 1995 Chicago heat wave, which claimed over 700 lives. His research on the medical, environmental, and social drivers of heat-related mortality became the foundation for modern heat health action plans. He later spent 15 years at the European Centre for Disease Prevention and Control, where he developed climate-based early warning system for infectious diseases. He's also a lead author of the EPCC 6 assessment report and a key contributor to the Lancet Countdown reports. Currently, Dr. Semenza is affiliated with Umeå University in Sweden and Heidelberg University in Germany. So, Dr. Semenza, the floor is yours.
Thank you, Doris. Thanks for the kind introduction. Can I share? Can you let me share? So I can't share. Someone needs to get out of this slide here. There we go. Can you see this? So thanks again. I really appreciate the invitation from Asper and Columbia School of Public Health for me to speak here today. I'll speak about health, early warning systems, and surveillance in a changing climate. And the next slide illustrates quite nicely what this is all about and what we are up against. Okay, guys, time to choose. Heat wave, heavy rains, or West Nile virus. In fact, I did speak about heavy rains and West Nile last time, but the question is, how can we anticipate these type of climate exposures and impacts? And that this slide basically summarizes my talk, where we want to go with this, because we need to anticipate these potential impacts on population health. So it turns out that in 1995, I received a phone call from a then supervisor at 9 o'clock in the evening, and she told me, "Hey, Jan, you're shipping out tomorrow morning to Chicago because there is a heat wave that has killed 700 people." I was just entering the EIS program, which stands for the Epidemic Intelligence Service. Incidentally, a program that has just been eliminated by the Bush administration, but it was basically the analogous program in the US, like the EPIET program in Europe. And we realized that the big inversion had locked in hot air in the city of Chicago. And when we assessed the media, we saw that this was actually a devastating impact. This slide here illustrates a photograph from the New York Times where a cooling truck had to be brought to the medical examiner's office, the morgue, because they couldn't handle this overflow of dead bodies, and they had to store them in this meat cooling truck in order to wait for autopsy. So it was a devastating situation, and the news were horrible across the board. Here you can see the different types of headlines. And please notice the type of headlines that we see here. I want to come back to the way this was communicated at the time, because this is essential to understand what went wrong at the time. Anyway, so we came to Chicago and got this very warm welcome in the city of Chicago. In fact, it was extremely hot, but it was not just hot climatically, it was also a hot political situation, because it turns out there was a big controversy between the medical examiner, his name was Ed Donahue, and the mayor of Chicago, Richard Daley, because Richard Daley said the medical examiner is just overinflating these heat-related deaths just because it's hot out. Of course it's hot out. We all know that, but that doesn't mean that these people died because of the heat. The medical examiner insisted that he had never seen anything like this, and this was a true epidemic and environmental disaster, as you can see here on this paper clip. So we basically decided to evaluate the surveillance systems, or the case definition that the medical examiner had used to assess an individual as being heat-related or not. And so we went through the case definition, and here I'm reading persons with a core body temperature of 40 degrees or so or greater measured at or after. Naturally, this is often very difficult to do, because you can't just measure someone's temperature when that individual has died, because you might have missed the window of opportunity there. But there's a second part of the case definition: significant evidence of heat as a contributor to death. For example, all windows were closed, no air conditioning or high ambient temperatures or something like that. And again, that's often also difficult to establish. And so the third, more circumstantial line of evidence will be cases that were deceased and at least seen alive during the heat wave and later found dead and decomposed without evidence of other cause. And so we basically assessed this case definition, and we saw that this case definition had been used over the last 20 years or so and not changed since. And so we basically published an article in the MMWR, which stands for the Morbidity and Mortality Weekly Report, the CDC publication. And we basically stood with the medical examiner and told the public that we actually side with the fact that this was a true disaster, and environmental disasters of unknown proportions at the time. So when we analyzed the situation in more detail, we saw that the heat index, which is a combination of temperature and humidity, we saw that this heat index skyrocketed very quickly early on in July, and then it was followed by a spike in these heat-related deaths, and we included both cardiovascular deaths and heat-related deaths in our case control study. We set up a matched case control study of these individuals that are plotted out on this dot map here. This is the city of Chicago. The red dots in the southern part of Chicago represent African Americans that died, and the bluer dots represent white people up there in the northern part, because you can see that the city is very much segregated by race. And so we went to all these households and tried to figure out what's the difference between a person that died and the person that didn't die. And I don't want to go into detail of this investigation. It's a very multifactorial issue, obviously, but just focus on one thing. The one overarching thing that we discovered was the fact that social isolation was one big driver of heat-related mortality in Chicago in 1995. Those people that participated in group activities, clubs, churches, and so on were less likely to die. Those people that had friends in Chicago were less likely to die. Even those people who had a pet at home were less likely to die. But if you lived alone, you were more likely to die. And these slides here illustrates the rooms where people had died, cramped living conditions right under the ceiling, under the roof, where it got extremely hot. And you can see how terrible living conditions these people were living at, and then eventually died. And this slide illustrates most vividly and dramatically, I think, what it means to be socially isolated in the United States. These are coffins of individuals that are brought to mass burial because nobody claimed their bodies. Nobody knew who these people were. Nobody knew a relative of these individuals, and they were basically lined up here in a ditch and brought to mass burial because nobody knew these individuals. So the US at the time learned from this experience. And basically, we understood that we need to do something about this because heat-related mortality is entirely preventable. And we understood that there is actually a temperature threshold that we can use and even forecast to predict a potential hazardous situation. And if we understand there is such a threshold coming up, we can come up with a warning to the public. We can reach out to vulnerable populations with appropriate media messages. And if you remember those messages that I showed you earlier in the media, at the time, they told people three things. It's hot, it's hot, it's hot, right? We all knew that it was hot. There was no information in those facts. We need to tell people what to do, how to stay out of the cold, how to drink water, how to stay in a cool environment, how not to exert yourself. There are lots of messages that need to be conveyed to vulnerable individuals in order to have an impact. And we learned that we needed to build phone banks of vulnerable individuals to reach those individuals at the time of risk. And then guess what? In 2003, a massive heat wave happened in Europe as well. And we will hear about this 2003 heat wave later on in a second talk. But you can see that at the time, this was a statistical outlier. 2003 was the hottest summer in 140 years. And you had never seen anything like that. It was a statistical outlier. And in fact, as a result of that heat wave, 70,000 individuals died in the entire continent of Europe, mainly in the southern part of Europe, but the impact was unimaginable. As a result of that dramatic event in 2003, the Europeans started developing these heat health action plans as well. This is from WHO Euro, where they came up with these four different levels with forecasts, risk conditions, warnings, and so on. And these early warning systems were in fact effective to bring down heat-related mortality also in Europe. However, what happened? In 2022, Europe experienced the historically hottest period ever experienced at the time. And Joanne Ballester from IS Global calculated the mortality rates in Europe, and you can see that Portugal, Spain, Italy, and Greece were impacted by this incredible environmental disaster. And he computed that 61,000 individuals died in that particular summer because it was so exceptionally hot. And you know, I pay attention to the news, and I have to tell you that I have to admit, I did not hear that 300 airplanes with 200 people each crashed during that summer. I completely missed that because 61,000 people corresponds to 300 airplanes with 200 people each that crashed. And guess what? Nobody is talking about this. And my question is, what's wrong with us? Why can't we see that this is a public health emergency? Why is there no outcry? Guess what? The next year, 2023, again, the hottest period ever recorded now. Again, it beat the record, and you can see extreme mortality in Portugal, Spain, Italy, Greece, Bulgaria, and Romania. And if I summarize the facts here, in 2023, it was something like 70,000 excess deaths. In 2022, 61,000 deaths. And in 23, 47,000 heat-related deaths that occurred, particularly in the southern part of Europe. So my question to you is, why do our heat health action plans not work? Why can they not protect these people from dying during these extreme episodes of extreme weather? And basically, let's go through the different steps of the core components of these early warning systems. The first thing is obviously the risk characterizations. In order to understand the risk, we need to understand the climate hazard, the exposure, and the vulnerabilities that people display. Then the next thing you need to do, you need to monitor the situation, analyze and detect the potential disease risk. You need to issue warnings to vulnerable populations and respond and intervene with appropriate actions so we can reach those populations and reduce their risk. And so if we go through those four different steps, in more details. So this one here now looks at the risk. This was the first core component here. And I used the IPCC and a diagram of risk. Risk is defined by the climate hazard, vulnerability, and exposure. And in fact, it's in the middle of this Venn diagram. And obviously, the hazard can be reduced through mitigation. Vulnerability can be reduced through adaptation. And exposure can be reduced through adaptation also. And that then defines that risk at the heart of this Venn diagram. So how do we do that? We need to understand these exposure pathways of that people get exposed. So who is getting exposed? I showed you a slide under the roof where someone died. So if people live right under the roof with the black roof, for example, that attracts the heat, that's an exposure pathway, that's of concern. But also people working outside under extreme conditions, people that live in heat island, the urban heat island effect, where the concrete radiates at night and leads to these terrible exposures, and people can't take refuge from the heat even at night. We need to define these vulnerable populations. I told you earlier, the isolated individuals who are at risk in the US, but also the elderly, of course, and the extremely young, those individuals with pre-existing medical conditions, and pregnant women. So we need to define these populations at risk. And then we can define the health impacts from those climatic exposures, and try to find out the threshold when we see these impacts increasing. Then the next core component then is detect. And for that, obviously, we need to have surveillance. We need to set up monitoring systems for climate-sensitive health outcomes that involves both communicable and non-communicable diseases. Obviously, those surveillance systems can be passive or active. And my pet project are integrated surveillance systems where we're trying to link epidemiologic data on humans with climatic data, environmental data, determinants data, in order to make sense out of these complex multifactorial issues. And then we can develop these predictive models to generate forecasts and try to detect adverse health outcomes under scenarios like that. And this one here is a diagram that we had developed at the time, where we're trying to combine epidemiologic data with meteorologic data, entomologic data, water monitoring, air monitoring, and so on. That allows us then to merge them, integrate, analyze, and interpret them, and to inform the 10 public health functions, which is illustrated in this star diagram on the right. These are the 10 essential public health functions that can now be informed with this type of integrated surveillance, where we link climatic data with epidemiologic data to make sense out of what's going on. So, and then the third component here is the alert. So how can we assure that these warnings reach populations at risk? And stakeholder and community engagement is part of this alert. Build effective communication channels, identify target populations, and develop actionable messages. And if you look at these 4 different bullet points here, which one do you think is the most important one, and which one is probably the most difficult one? As far as I can tell from my perspective, I do think that community engagement is probably the most difficult one, because that requires outreach to these vulnerable populations and communities and try to engage them in these type of activities. And we in public health traditionally live inside the box. And you can see here that traditional public health deals with regulators and land use, agriculture, sanitation, and so on in a more passive communication way. So the communication doesn't really flow, because we live in this siloed pigeonholes, because our society is organized by disciplines and by sectors. And then it's a top-down approach to public health, where we set up these vaccination programs for smallpox or polio, which are very effective to reduce the risk for smallpox or polio, but it eliminates all the other underlying determinants of risk, poverty and marginalized populations and all that. You solve the polio issue, but you don't solve the poverty that puts people at risk for respiratory diseases or something else. And so this traditional approach to public health has been effective for targeted issues. But I think now with these multifactorial issues like climate change, we need to rethink public health. And I call this lateral public health, outside the box. We need to have a much more engaged conversation with different sectors in society and different members of society, like community and families and school. And again, the community is the most difficult one. And in fact, we developed strategies how we can engage social engagements of communities and engage them, make them sure that they participate in climate adaptation strategies through bonding by increasing the bonding social capital, which is basically the networks within neighborhoods and within social networks to increase the capacity within those groups, and then link those groups to administrators and mayors and officials that can help bring about change. We call this bridging social capital, to connect people with different types of power in order to implement collective action. And we have shown that this kind of an approach does in fact work, and this should be looked at into more detail. So I call this lateral public health, where we need to advance social networks to increase and bundle social capital among neighbors, for example, then bridge them with people with more power, like the administrators, to get the permitting issues through and change the built environment, for example. We need to increase community-based participation in decision-making for preparedness and response. We need to intervene on hazard exposure and vulnerability, as I mentioned earlier, and then make these connections between the different agencies, because we need to transcend the siloed confines of traditional public health. And so then the last objective here is the action. In this case, we would like to ensure timely response, to build capacity and competence, establish a line of command, develop response protocols, test and revise and action. And I don't want to go through all the different steps, but there are different steps that need to be implemented to develop these type of early warning systems that are out there. But I would like to tell you some practical examples. I'd like to show you one for arboviruses, chikungunya or dengue, early warning systems, or one for a waterborne disease, just as some practical examples. So it turns out in 2017, there was a chikungunya outbreak in Italy and France, and we analyzed all the incoming passengers that came from chikungunya activaires. Chikungunya is a viral disease that's transmitted by mosquitoes. In this case, the Asian tiger mosquito, Aedes albopictus, that's present in the yellow part illustrated on this map, at least at the time 2017. It has expanded since. And so we looked at how many people are potentially coming into these areas where the mosquito is present. And then we computed you can see here, this is where the outbreaks happened in the southern part of France and in Italy. And we basically then computed the vectorial capacity or the climatic suitability for transmission. And you can see that July and August were areas where the mosquitoes present that were conducive for transmission, much less so in September and October. And we used Twitter at the time, X called now. We could identify individuals that moved from the Var district here in the top left corner to Rome. If an individual tweets in Var, we can connect them where these people go, and we can see that there was a connection with Rome. And we can now connect these two epicenters of the epidemic by using these type of Twitter feeds to see where people tweet first and where they move then, to connect those outbreaks. So what I'm trying to say is that there's potentially early warning systems that we can develop where we monitor the importation risk and population movement, and we can then monitor climatic suitability for transmission once an individual has been brought into an area that's suitable for transmission. And if that individual is viremic for the virus, then that can potentially lead to an outbreak if that individual is bitten by a mosquito. So we need to eliminate the vector breeding grounds, set up seasonal surveillance for these cases, which is available currently in France, Portugal, and Italy, exposure control to put out screens on the windows, vector control to eliminate vector breeding sites, detect new cases, verify those cases, notify, and intervene in order to bring that epidemiologic curve. And when I was at ECDC, I built a system like that where we looked at climatic suitability and importation risk to have a handle on potential risk zones where we need to enhance our surveillance for potential outbreaks. Another project is this one here, where we evaluated all the surveillance systems for infectious diseases in Europe with a particular focus on climate-sensitive infectious diseases. And so we basically ranked these diseases according to whether they were strongly associated with climate or climate variability, and much less so. And then asked the question, what if a disease is highly associated with climate change? Does that mean that we need to take public health action? And we decided not necessarily, because if there isn't a big impact on society, it doesn't matter if there's a big impact of climate change on that pathogen or that infectious disease. But once we set up this weighted risk analysis against the impact on society, we come up with this matrix here. And you can see that now different diseases have different emphasis. For example, Lyme borreliosis needs to be put under surveillance. At the time, in fact, it was bolded here in this diagram, there was no continent-wide surveillance for Lyme disease, but now we have Lyme borreliosis surveillance, neuroborreliosis, on a European scale after this paper was published. Then there is no dengue surveillance, but TBE, tick-borne encephalitis, has been put under surveillance after this paper was published. And then Rift Valley fever, chikungunya, visual leishmaniasis, all these diseases didn't have appropriate surveillance systems at the time. And one that I would like to focus on is a waterborne disease. These are bacteria related to cholera, but in this case, these are bacteria that do not cause cholera, but they cause Vibrio infections like wound infections and gastroenteritis that are potentially very dangerous, because if we have an increase in global temperatures, we have an increase in sea surface temperature as well. It turns out that the oceans have absorbed 90% of the heat from global climate change. And so that's where all the heat is stored. And so this increase in sea surface temperature leads to a propagation of these Vibrio bacteria, particularly in brackish water. And then people get exposed to these bacteria, and they can lead to fatal infections, septicemia, and wound infections that are a huge concern for these individuals. And so, again, we would like to propagate the fact that one could manage sea surface temperature and salinity as an environmental signal, set up active surveillance for case finding, and then response by setting up beach closures and alerts to the public to avoid people from getting exposed to these kind of waterborne infections. It turns out we build a system like this, the ECDC Vibrio Map Viewer, that is in fact to date the only operational early warning system for infectious diseases, where we monitor these sea surface temperature and salinity on a regular basis. And then in the summer months, we come out with alerts to the state epidemiologists and tell them that this bay is at high risk for these type of infections because the environmental suitability is high. So this is now a tool that's operational at ECDC. And we did in fact see this in 2014, that the environmental signal corresponds in fact to an epidemiologic signal as well. So in summary, early warning systems can trigger early warning and response to health threats, thereby reducing morbidity, mortality, and economic losses associated with climate risk. So there is, in fact, an incentive to implement these type of systems, because, in fact, there are low regret options, because they can be used not just for climate-sensitive infectious diseases, but for all kinds of other health endpoints. And by strengthening these kind of early warning systems, we can enhance and advance climate resilience of our health systems. So they should be considered as a wider approach to tackling these potential threats to public health from climate change. And as I mentioned earlier, these core components of early warning systems include these health risk assessments by looking at the climate hazard that interacts with exposure of these individuals. In the case of heat-related mortality, I mentioned the heat island effect and individuals working outside and sports and things like that could potentially increase that risk. And then obviously the vulnerable populations, all the socially isolated ones, the elderly, the very young, pregnant women and people with pre-existing medical conditions, cardiovascular issues that are at increased risk. So that defines the health risks. So the nexus of hazard, exposure, and vulnerability is something that we need to take into account to understand the risk. But we do, in fact, have the option now to monitor these type of risks, analyze the data, and then potentially detect a signal if we see that the hazard is lighting up in our alert. And then we can then come up with a warning, particularly a warning to vulnerable populations. So building these phone banks and networks to make sure that we reach vulnerable populations and that we can make sure that these people take the precautions that they need to take in order to protect them from heat. And then once we have done all that, we can then mount an effective response by bringing vulnerable individuals into a cooler environment, into a cooling shelter. It could be a shopping mall, a movie theater during the hottest time of the day. Make sure that we move them out of the heat, particularly people that work in agricultural work. They are at risk for kidney damage. One thing we found, in fact, was acute renal failure due to extreme heat exposure. And so the effective response will be to remove the exposure from those vulnerable individuals and move them into a safe space. So in conclusion, the 2022 and the 2023 extreme impacts of heat waves during the summer months was a wake-up call for all of us that more needs to be done to advance these early warning systems, because they are working, but they're not working well enough. And everybody needs to think outside the box to approach this. I call this lateral public health, to break the barriers of traditional public health, to connect with different sectors and communities out there to respond to these potential climate hazards. And by doing so, I think we should be able to bring down these incredible health impacts. Here, the most important slide, all the individuals that participated to the work, and any questions, here is my email. And again, funding from the European Horizon Project is very much appreciated. And I leave it at that. Thanks.
Thank you so much, Dr. Semenza, for this insightful presentation. It really highlights a critical issue that affects both the present and the future, and personally, it has been a great source of inspiration for me. So thank you. We will save the question for the end and move to the next speaker. So I'm pleased to introduce Dr. Polychronis Kostoulas, that will present the first case study. He's an associate professor of epidemiology at the University of Thessaly. He has spent over 2 decades specializing in public health epidemiology, focusing on Bayesian approaches for diagnostic test validation through prevalence estimation, confidence in the disease absence modeling, and the development of early warning systems for epidemics. Dr. Kostoulas has extensive experience designing public health intervention campaigns and risk analysis, and he also serves on the executive board of ESHPM. So please, the floor is yours.
Thank you very much. Can you hear me?
Yes, you hear you.
And now you see my screen, I hope. Yes?
Yes.
All right, great. So thank you very much for the invitation. I was very, very happy to listen to Jan, because he raised several points that are very, very crucial when it comes to early warning systems in disease and epidemics in general. And I was really happy to see that most of the critical aspects that are needed when you have to have an early warning system today were raised. I will briefly point out a few key points when it comes to early warning systems for upcoming epidemic waves, and we will give you an example of a tool that we have created and helps us to identify epidemic waves early, and in this way take preventive or actually proactive action to mitigate the consequences of these epidemic waves. First of all, I would like to say that what we mean by fast has changed over the years, all right? And if we compare the 1919 to the current COVID-19 pandemic, we will see that, and at that time, the global span of the pandemic that took 2 years was considered fast, okay, because we have the World War, and 2 years was very, very fast. But nowadays, fast is only 3 months, and this is because we have a rapid transportation, the modern transportation, the rapid modern transportation of humans, animals, and products, which means that we have to be alert, okay? And we are not sure, we are not waiting something to come to us from the next door, okay? It can very well come to us from very, very far apart because of this fast movement of humans, animals, and products. And this is why, as Jan raised before, we do also need to move forward from classical spatio-temporal dynamics and so on to network analysis, as he very nicely pointed out with the Twitter messages, where they come from and how this indicates where the next spot of an epidemic can be. So when it comes to rapid detection and response, the idea is that we have early identification, and by doing so, whether it's a known or an unknown new pathogen, we have more time to act, and by doing so, we implement control measures, we take action, and we eventually reduce morbidity and mortality geometrically. And that's why it's very important to have proper surveillance systems, and based on these surveillance systems, to have early warning systems. And of course, one very critical aspect is syndromic surveillance, because with syndromic surveillance, when syndromic surveillance is in place, we can spot non-specific indicators of disease, and in this way, we can spot emerging or re-emerging or unknown diseases. So very briefly, we have data-driven surveillance networks and sentinel networks. We have very diverse modeling approaches. I am very, what is really important is not the modeling part. The important part when it comes to predicting early is having a proper surveillance system, okay? And this is the basis. Even the moving average can give you an indication of something happening, okay? The important part is to have an early warning system, ideally interconnected between regions and countries. And of course, another way of early warning systems is based on vectors and environmental surveillance, because obviously there is a link, especially for vector-borne diseases, between environment and the ability of vectors to survive in the case of several diseases that are now coming to Europe and have been endemic to Europe over the last 20 years, like West Nile and other diseases that are giving us potential spots of epidemics like dengue in Italy and other viruses. So what we have created at the beginning of the COVID-19 pandemic is a tool that can be used to predict a coming epidemic wave, and it's based, instead of being based on the newly reported cases, it's based on the volatility, on the number of cases reported. And I have here this is appeared in Nature Scientific Reports as a first publication, and I have a very short video explaining the basic idea behind the tool. I think we could. Okay.
We're going to explain the basic concept behind the Epidemic Volatility Index. EV. Let's say that we have observed the number of new cases for 10 days. We first calculate the standard deviation for a rolling window of a size we pick, for example, 10. When a new observation comes in, we calculate our next standard deviation by moving the rolling window one step forward. Now, we can also calculate EV for the first time, because EV is calculated as the relative change between two consecutive standard deviations. And we keep doing this as new cases are observed. Here is a region without a marked rise in cases or the calculated standard deviations, but with a visible change in EV. Not just this first point that looks like a spike, but also the next three. This rise in EV is an early warning for a coming epidemic wave.
Okay, this is how EV works, and following its application on COVID-19 data that we retrieved from Johns Hopkins Daily, and with which we managed to demonstrate that it effectively identified most of the upcoming epidemic waves in all countries and in all states in the United States. We also tried to implement a surveillance system at the local university hospital, and we did so successfully monitoring respiratory infections, influenza, COVID-19, and recently RSV. And this also has been giving us early warnings for our region, and the doctors can prepare themselves of what is coming, and we know whether a wave is coming and how to treat it, and whether it's just a respiratory infection that is not expected and we should do something more, or it's COVID-19 or flu. And at the same time, we have also been applying this in collaboration with OIE to monitor avian influenza cases globally, where this is an ongoing project. And as you can see, when we have a red dot, there is a wave coming. And you can see that even in this case, the epidemic volatility index identified the coming epidemic waves. EV is based on the volatility rather than the absolute increase of the cases daily, or even more than once daily, but ideally daily. And it gives us an early warning and the necessary time to act proactively and to mitigate mitigate the risks and constrain the negative consequences of an epidemic. And in fact, as I was listening to Jan's talk, I thought that this may be a tool that we can also apply in temperatures and have an early warning based on the volatility of temperatures that can be associated with the expected number of deaths after a heat increase. Because I know that it's not just the rise in the temperatures, but it's the volatility in the temperatures that is affecting at least cardiovascular diseases. And as we are exploring more and more ways to implement EV in different settings, I think that implementing this in monitoring of temperatures would be a good idea to have an early warning of what may result in a heat wave and an upcoming, of course, with the consequences in terms of deaths due to heat. And with this, thank you very much.
Thank you, Dr. Kostoulas, for this presentation. As previously, we will save the questions for the end and move to the second case study and presentation by Dr. Guillaume Boulanger. He led the Quality of Environment and Work and Population Health Unit at Santé Publique France, the French public health agency. Their work focuses on monitoring and assessing the impact of environmental and occupational factors on population health. Their unit plays a key role in addressing climate-related health challenges, and they also led research on the health effects of heat and develop health indicators to support climate adaptation. In addition, Santé Publique France participates in the International Association of National Public Health Institutes and coordinates a working group focused on climate adaptation. So, Dr. Boulanger, please, the floor is yours.
Thank you so much. Do you hear me and do you see my screen?
Yes.
Perfect. Okay, thank you so much. I'm very delighted to be with you today, and I would like to thank you, of course, ASFER, for this opportunity. Today, I will present you the French heat warning system. Just a few words about the starting point. This starting point is the heat wave of 2003. This heat wave was a dramatic episode with unprecedented mortality impact. More than 50,000 people died during this summer, and all the population was concerned, especially in the urban center. The communication was clearly inefficient during this episode, and the risk was underestimated. The death occurs very quickly, less than 1 day after exposure. More generally, concerning the impact of heat waves on mortality, we estimate that more than 42,000 excess deaths were observed during heat waves since 1970. And unfortunately, we observe an increasing impact despite prevention and alert efforts. We observe more than 11,000 deaths in the implementation of the Heat Health Action Plan in 2004, and more than 80% of the impact was observed between 2015 and 2024. It's very important because we observe a very acceleration of climate change since 2015 and a significant impact of heat waves since 2015. In parallel, we also estimate the economic impact of the heat wave, and we estimate that 21 billion of euros was due to heat waves between 2015 and 2019. So a national Heat Health Action Plan was implemented by the Ministry of Health in 2004, and this plan was implemented in order to inform and train on the health impact and protect the vulnerable people. The action related to this Heat Health Action Plan were activated from June to September. A part of this plan is operated between Santé Publique France, the Ministry of Health, and Météo France, which is the National Weather Forecasting Agency. The action of this heat warning system covers the warning decision, the health surveillance, communication, and prevention during heat waves. Of course, one of the main objectives is to understand the main impact and opportunities for prevention, and this system is clearly focused on the most dangerous heat waves. Regarding the heat wave alertness levels, these levels are under the supervision and the responsibility of Météo France, the National Weather Forecasting Agency, and are declined into 4 levels. First, the green and the yellow levels, which correspond to normal temperatures and a slight heat episode. And we are more concerned by the orange and the red alerts, which correspond to heat wave and extreme heat wave. Just keep in mind that in the heat health action plan, an heat wave is defined as a period of at least 3 days of heat, which correspond to the average of the maximum and minimum temperature over 3 days, above alert threshold defined by department. And also keep in mind that there is, of course, a risk of mortality for temperature below this threshold. This threshold were set up in 2004 by Santé Publique France, and this threshold corresponds to a percentile 99.5 of the historical 3-day average minimum and maximum temperature distribution in the department. And this threshold corresponds to a doubling of mortality in the absence of management prevention measures. Therefore, you see that there is a significant risk of mortality related to this threshold. So, concerning the syndromic surveillance, Santé Publique France activates this surveillance from orange vigilance in at least one department. And during this period, we collect and observe visits to the hospital's emergency room and GP's emergency association for a specific indicator related to heat called high heat wave. And this indicator groups hypothermia, hyponatremia, and dehydration. Our system is quite representative because we cover data from 95% of the French hospitals and 98% of GP's emergency association. Our system is also robust and reactive because data are available at day +1 and robust at day +4. Just to illustrate some results, we observe more than 140,000 hospital visits and more than 31,000 GP visits related to this indicator high heat wave from 2015 and between 2015 and 2023. More than 80% of this emergency care occur outside heat warning period as soon as temperature increase, but the morbidity peaks are observed clearly when a large part of the population is concerned by the heat warning. On the graph on the right, you can see clearly the same trend between the population exposed to alert, the orange alert and red alert, and the use of emergency care. In dark blue, the hospital emergency, the visit to the hospital emergency room, and in light blue, the GP's emergency association. Regarding the mortality, we have two complementary indicators. Based on the same source. It's based on data from consolidated after 1 month, so we are not very reactive concerning this point. And the first indicator is estimated excess of death. We compare the observed deaths to expected deaths based on a Euromomo model. And this estimation is produced during the heat wave period, but this estimation takes into account other factors of risk. For example, if we have a heat wave and COVID, we have a synergistic relationship between these two factors. And also, when we have heat waves and forest fire, of course, these two factors influence the estimated excess of death. We have another more specific indicator. We estimate the mortality attributable to heat, and 2 years ago, we have developed a model to estimate the mortality specifically attributable to heat with a time series analysis between mean temperature and mortality, and taking into account seasonal effect, COVID effect, and long-term trend. Of course, we cross this temperature mortality relationship with the mortality data observed for the period considered. And it's interesting to underline that we estimate this mortality attributable to it during all the summer and during heat waves. So we have two complementary approaches related to mortality. Just to illustrate the significant impact of it, I would like to present some results. First, 34,000 deaths were attributable to it since 2017, including 9,700 during heat waves. So 30% of the mortality is attributable to it during heat waves, which represent only 4% of the day during this period. So it means that during heat waves, we have a very high mortality. And this justifies the very focused action and the reinforced action during this period of heat waves. But it means also that 70% of the mortality occurs during the other day of the summer. And this is a very important burden of disease. And this underlines the need to reinforce the adaptation and mitigation action. Concerning publication, I will not detail this slide, but keep in mind that during the activation of the health surveillance, we communicate very closely with the Ministry of Health every day. And it's also important for us to inform the general population. And for that, we publish every week during the activation of the health surveillance a report. And at the end of the season, we publish also a summer report summarizing all the data. So one of the questions was the upcoming challenges. Just keep in mind for the key points that our heat warning system is robust. It was developed in 2004. It's very effective, and for instance, during last year during the Paris Olympics, and it's important for us that our system, our heat warning system, is known and recognized by the authorities and the population. But it's clear that after 20 years of existence, we need now an evaluation of this heat warning system. In parallel of the health surveillance, Santé Publique France is also in charge of prevention action, and for that, during the activation of the orange and the red alert, we broadcast some paper media for the healthcare professional, elderly people, vulnerable and young children. And we also broadcast digital out of home, digital, and sometimes TV and radio spots. Of course, the climate change is very huge and next challenge for us, because we observe clearly an impact of heat on health during all the summer. So what awaits us? Of course, we expect an increase in the number of events. We expect heat waves more longer, more intense, and more widespread across the country. On the right, you see this figure with the number of days associated with heat waves and the intensity defined by the temperature. And here you can see the historical heat waves with the heat waves of 2003 and the projection are very we are very concerned by the projection because in terms of intensity and the number of days. Moreover, the French population is aging, and for instance, the number of people aged 75 and over who are very vulnerable to it would have tripled in 2015. And of course, we are very concerned by an evolution of our heat warning system. And one question is if we multiply the number of alerts, of course, the population will no longer be aware and will no longer be listen the prevention alert. So how manage the multiplication of the alert in the future? And of course, one of the challenge is to take into account other risk related to climate change, like forest fires, ozone pollution, or infectious disease during this summer. So thank you for your attention, and if you have any question.
Dr. Boulanger, and thank you to all three of you for taking us inside this topic with such interesting examples. We received a lot of questions, so I don't want to take up any more time, and we can start with the first one, directed to Dr. Semenza. So, to what extent did the heat-related mortality of 2022 and 2023 impact on and cause distortion of excess mortality calculation post-COVID?
For example, the 2003 heat wave had a huge impact because there had not been anything prior to 2003 for a long time period. So you have elderly population that accumulated, and that susceptible pool then took a disproportionate impact, and that's why we saw this incredible peak in mortality in 2003. It's very possible that something like that happened in 2022 as well, that COVID had something to do with that. But these calculations are based on the exposure response curve of the heat and mortality rates. Obviously, COVID could have something to do with that, but these are calculations where you use the exposure response curve to estimate the impact.
Okay, thank you very much. Just a quick note to the participants, as we still have a little bit more than 20 minutes. Please feel free, if you haven't done so, to add more questions. You can always note if they should be directed to one of the speakers directly or to more of them or all of them. I will just continue briefly to you, Jan. There have been quite some questions that I'm going to summarize because they go into a very similar direction. And the question is about differences in susceptibility and in terms of the baseline of the population that you see in different parts of the world, different parts of Europe, in terms of age, sex, ethnicity, heritage, and regular climate, in this case, temperature conditions. How does this feed into the models that you developed in the last decades, and how is this respected, and which influence does it have on the predictions that you do in your early warning systems?
Yeah, so good question. So basically, all these models have to be adapted to a local setting. So people get used to their normal environment and their normal climate, and so people acclimate to those conditions. And so every exposure response curve is designed for one specific location because the conditions are so difficult, so different, and that's why you need to apply different exposure response curves. It needs to be done on a local level. Even the heat wave definition needs to be defined for every single location. And what has been done in the past is to look at the temperature distribution for one location and then look at the 97th percentile. That's then everything that's above that is categorized as a heat wave. And again, it has to be done for every single individual location because that response to the heat wave depends on by location. So it has to be broken down into not 3 levels or smaller units in order to make sense out of all that.
Okay, thank you very much. That makes sense. Doris, you would like to continue with the next question?
Yes, thanks. I think we can go to a question to Dr. Polychronis. So how can you remove the false positive of EVI?
There are false positives and false negatives, of course, in every system, and it's a matter of determining the cutoff. Generally, for an early warning system, we don't want to remove the false positive, but rather the false negative, in the sense that we like it to be non-specific, and even if it gives us a false early warning, we kind of are willing to accept some false positives and not having the risk of having some false negatives. So it's a matter of cutoff selection. If you want to remove the false positive, you can do this, but at a cost of perhaps missing some early warnings. Right now, as the system is, and of course you can do this through we have an R function, an R package and a stata package that everybody can use, and they can modify this in the settings. As it is right now, it minimizes overall the false positive and false negatives.
Okay, thank you. Polychronis, maybe just to stay with this topic briefly, I would like to add one more question to the EVI concept. And there is one question coming from Heritage, and it is how can the EVI predict the peak of a spike of infections in a change of direction of number of cases, so that health planners can know when or how soon the numbers of new cases will go down again, if this is even possible.
Yes, it is. So when EVI turns red and you have 2 or 3 consecutive red dots, this means that there is an upcoming wave, okay? When EVI turns gray again, you are close, so you have a deceleration and you are reaching the peak. So when the EVI gets gray again, you have again a series of gray dots. This means that you're close to reaching the peak, and you are to expect a decline after some time, depending on the disease, of course, okay? It's disease specific.
Okay, that makes sense. Thank you very much. Doris, going on with you, any other questions?
Yes, a question for Dr. Boulanger. How adaptable is your alert system to other regions of the world? And another similar question is about Africa, how we can adapt it to the African territory.
Yeah, it's a very hard question. I think the more precious indicator is temperature, and our heat warning system is clearly based on temperature, and as Jan mentioned before, the distribution of the temperature, and maybe you can base this heat warning system in all the world based on the end of the distribution of temperature, and clearly to implement a neat health warning system based on temperature and preventive action related to protect the population. And of course, in all the country, you have maybe not very specific or data concerning the use of emergency care, but you have data concerning the all causes mortality, and you can decline some study to elaborate a relationship between mortality and the mortality and temperature, and you can see if you are consistent between the high distribution of temperature and the calculation between mortality and distribution of temperature.
Okay, thank you very much, Guillaume, for clarification. I will direct three other questions to you, Guillaume, because your presentation has definitely sparked some interest in the details of the health impact assessment that you have done there. One part of this question goes into the economic, and the other part goes into the more health-related part of the health impact assessment. So the first part comes from Agnes and Arnaud. They would like first a clarification. When you speak of billion, do you speak of European billions or US American billions? And how exactly did you assess the economic impact of the heat waves on the French nation? And the second part coming from Lisanne is whether there have been measured any DALYs or QALYs, so disease-adjusted life years or quality-adjusted life years in your assessment.
Okay, thank you for the question. Maybe I can share a publication because it's published in the literature. This estimation, and the economic impact was estimated in euros, not in dollars, in euros. And this estimation covers the cost linked to mortality, linked to the emergency care, and the loss of production. So it's very important estimate. And the last question was the use of daily or quali.
Yes, exactly. Whether they have been analyzed as well. Yes.
No, I'm not the author of this publication, and it's not clearly my skills. But I remember that the economic impact was based on the use of the number of, for instance, the number of use of emergency visit in hospital, and the price, the cost of this emergency care. So we don't use DALY or QALY, but directly the number of emergency care visits and the cost associated to this emergency care visits.
So I think we can come back to the Dr. Semenza with another question about high mobility population. So if those models are looking to refugees and highly mobile populations.
So there are different types of mobile populations, right? So one population are the tourists that go into endemic areas and then potentially bring pathogens back. And then you have trade, right, where vectors are potentially being transported from one location to another, like used car tires that are moved from one continent to another and bring new mosquito species to a location. And then you have migrant populations, right? People that are forced to move because of climate conditions in their home country, and then they're potentially impacted by climate in transit and impacted by climate in the destination country as well. So those are three different categories of population movement that we need to consider. And we have done quite a lot of work on the importation risk of pathogens from tourists that come from endemic areas because they can arrive within the viremic period where the virus is still in their blood, and then a mosquito can pick it up. But the dispersion of Aedes albopictus throughout the world through trade is another huge issue. It's the most invasive species out there, and you know how many billions of people are now at risk for these arbovirus infections as a result. So it's a disaster. And we also looked at migration populations in the third category, because the question is, are these people at risk for disease transmission among themselves and the risk to the host population? And during the 2015 migrant wave, we analyzed the risk of disease importation into Europe from Afghanistan, Iraq, and Syria. And we didn't see a big risk to the host population, but we did see a risk of transmission within the migrant populations if they're housed in substandard conditions, and that's where transmission happens. So there are different things you can look at here and tease out different drivers of disease transmission to reduce the risk.
Okay, thank you very much, Jan. You have definitely sparked some interest, quite some interest on the question of community level engagement and possibilities there. So I'm going to summarize 3 questions here from Lilanga, Andre, and Brian. The first one is going into the direction of mitigation. So have you seen community engagement models that effectively work into climate mitigation, or are they always intrinsically linked to adaptation as well? And the second part of this question would be, how do you see the future role of primary care on family medicine or general practitioners in a widely dispersed geographically community? And maybe just a general elaboration on community-based early warning system and the engagement, as you have shown. This is probably one of the most challenging part of the whole linkage.
Yeah, I agree with you, Eric. That's exactly right. To engage communities, that's the hardest part. And let me give you an example. So this is an example that's mentioned in that Lancet paper that I mentioned on the lateral public health one. For example, in 2008, there's a river in Nepal that splits like a fork, right, into 2 different branches. And one village was built on the Karpali side of that river, and the other one on Babai, a different branch of that river. And so in 2008, these 2 communities were trying to engage in flood awareness. And the Karnali community, they very much engaged in broad-based community, well-functioning structure of preparedness and disaster management for potential floods along the river. And so they were doing everything they needed to do. They elected a community disaster management committee where they enhanced flood awareness within the community. They increased the response capacity, set up an early warning system to measure the gauge of the river to see if there's a flood coming. And then guess what? Sure enough, 2014, they had the biggest downpour ever reported in Nepal. They never experienced anything like it. And in the Karnali community, where people were engaged in the early warning system because they were part of the decision-making process, they were able to sound the alarm very quickly. They measured the gauge, they communicated the alert. People were woken up from their sleep because it happened at night, and people were able to move their movable assets out of harm's way, and people were able to protect themselves and their assets because of the early warning system. However, on the Babai River, same climatic conditions where they didn't engage, everything went wrong because the gauge meter wasn't able to measure the height of the river. They weren't able to sound the alarm properly. Once the executive got the message that there should be a warning, they didn't consider that as a strong enough threat, so they didn't really rank it as a top threat. And so basically what happened was that in the community where there was no engagement for the early warning system, thousands of people were displaced and people got killed, whereas in the other one, people were protected and they were able to save their assets. So this is a great controlled experiment where community engagement is essential for early warning systems. If you cannot engage your stakeholders and particularly your community, the most sophisticated, refined early warning system is just not going to work. You need to engage the community in both the decision-making and the engagement with the response to have the biggest possible impact of that early warning system. So that's the answer to that question. The other one was mitigation, and I'm not exactly sure whether early warning systems have been used for mitigation purposes. I would have to think about that. And the other one is about the primary care. So I'm not exactly sure where the early warning system will be used for primary care. You mean alerting the hospitals?
So this is I'm taking up the question here again from Andre. So the exact question was, how do you visualize the future role of primary care and family medicine or general practitioners, which is dispersed geographically in communities, in meeting the challenges of community engagement, the most challenging component of the early warning systems, as you have just pointed out. So is there any leverage to be taken from having this network of health practitioners already on site to combine them in or to introduce them in the early warning system?
Absolutely. I mean, the family practitioners, the GPs, they're essential. They are the pulse of the community to monitor what's going on in the community, and being able to detect influenza-like symptoms is essential for early warning systems for influenza in particular and other viral diseases, respiratory diseases, for example. So having an active, engaged family practice is essential for these type of early warning systems from the healthcare perspective. So I totally agree with you. We need to strengthen family practice and embed them both in the community and in the hierarchy of the alerts to protect the health of the public in the long run.
Yes, yeah, makes sense. Absolutely. Thank you. Thank you for also providing this very interesting example from Nepal. So maybe with one last question to you, Jan, I would like to slowly come to a conclusion here. That is one question from Tsepo. He thanks you very much for the insightful presentation and asks, how can health systems utilize AI to enhance early warning systems? And what, in terms of costing, how much will it cost to implement early warning systems in the public sector setting?
That's a great question. So thanks for bringing that up. So last time when I spoke about West Nile, we did in fact use artificial intelligence and machine learning to look at the underlying drivers of West Nile fever. And we used XGBoost, which is a machine learning technology, to analyze a lot of variables that could potentially predict the risk for West Nile. And by using that, we were able to see that spring temperature is one of the early predictors of West Nile later on in the season. But the most interesting part of that analysis was the fact that temperature variables were much stronger predictors than entomological data. So mosquito presence or absence was less much important, which is crucial for an early warning system because entomological investigations are very time consuming and costly. So in our analysis, we found that we don't need to have all the mosquito data as part of our model. We can rely on bioclimatic, so climate, environment, and even sociodemographic information to develop a system that works, an early warning system that works by using artificial intelligence, because artificial intelligence can test so many more variables than we human can, and they can look at thousands of interactions that we basically can't do manually. You know how difficult that is, and the machine can do all that, and we can develop very refined early warning systems by using artificial intelligence. And I was in fact at a meeting with Bill Gates a year ago, and they brought up that question. What do you see? How can artificial intelligence be used for public health? And I told them, this is a sore point, because Google and Facebook and all these big, Apple and all these big companies, they suck the oxygen out of the room by taking all the talent. Everybody who has talent in the field works for these social media companies as opposed for the common good. So we need more capacity in the field, and we need to strengthen these type of approaches. I totally agree. This is the future, and we can have a huge impact if we use these type of methods effectively for public health purposes.
Okay, thank you very much, Jan Semenza. And I think, Doris, if you agree with this last contribution, I would like to slowly come an end of this session. So before doing that, I would like to remind all participants again, thanks first of all for attending the session as well. It has been a great pleasure. Please, you would do us a great favor if you could just spare a couple of minutes to doing the survey afterwards. This would help us immensely. And then, of course, I would like to take this last minute to really thank you, Polychronis, Jan, and Guillaume, for taking the time out of your very dense calendar and agenda to present your case studies and lecture here today. This is very much appreciated. Yeah, with these last words, Doris, anything that you would like to add?
Not only say thank you because it was very interesting and very insightful, and hope to see all the participants in the next lectures.
Yes, so do I. So thank you all very much. Have a great day or evening or night, depending where you are, and see you next week at the next session. Thank you very much and goodbye.
Thank you.